All right, guys, welcome back to the second episode of the SmileLine podcast. We got Dr. Sam and myself today, and special guest Bear. He's going to be joining us along today.
Dr. Baggins on the scene.
That's right. So, Sam, you ready to learn about what we're going to talk about today?
Yeah, hit me with it. I'm ready.
All right. So, we're going to discuss the topic today of, do I save my teeth, or is it time to get them replaced?
Yeah, foundational question.
Yeah, we see this a lot in the consults. Patients come in and they're like, I just want to restore either this quadrant, whatever it may be. And then we get into the discussion, well, is it time to address the entire issue, or are we just looking at fixing the one problem area?
Yeah, so it's a big topic, but I think we can kind of dive into some of the common factors that we see that correlate between patients that a lot of times need to consider replacing their teeth, and then kind of the antagonist or the reciprocal of that, those factors as well. I mean, what we most commonly see is patients that either absolutely know they want to replace their teeth, or patients that absolutely know they want to keep their teeth. And the tough part is sometimes a patient's desire doesn't match maybe what the objective factors like the x-ray, like some of the gum health issues and cavities, things like that. Sometimes it's hard for us, and we sort of, I know we've talked a lot of times when the patient's expectation is that really there's not that much wrong. They know they got one or two things wrong, but we look at their x-rays and the objective criteria, the photos, the gum health, and the amount of decay, and we go, oh man, we've got a big conversation here today, because we've got to try to educate this patient from thinking that there's really not a lot wrong to realizing that spending money on a bad situation is probably, putting good money into a poor cause.
Yeah. So a couple different areas, and I'm going to come back to that one. But the first one is I want to dive into the new tool we're going to roll out here, and with the tooth setups, whenever we're looking at, replacing them or keeping them, and what we can do, in the design software with the replacements and for the patient's expectations. And then we can let them visualize and see that.
Yeah, historically we've done these consults in a way where I started by describing with my hands, my words, what I was trying to get the patient to understand was my solution for them. And, as we've progressed and as we've familiarized ourselves with different technologies, we've tried to represent more and more visually for the patient what that solution is. Picture's worth 1,000 words. So in our mind, the quickest understanding is something that you can see tangibly instead of sort of envisioning as somebody describes it when you're talking about complex dental solutions, which is usually what we're dealing with in these situations. So then we kind of evolved from just explaining it to schematically drawing it out on a tablet, and we still do that some today. It's a pretty handy feature. To where on the patient's x-ray we can draw on there and they can sort of appreciate what we're going to do. And we want to take that a step farther, that I'm super excited about this. I want all the patients to be able to see what our solution is in the design software before they have to really invest themselves in the solution. So I think understanding is so important, and we're going to take a set of digital scans when they first come in. Everybody that gets a consult will get a set of digital scans and photographs, and the scans will be used to virtually design a new set of upper and lower teeth. And that will help the doctors make the diagnosis for whether we can just do one arch, whether we can do both arches, or whether we even should go down the road of looking at prosthetics, or maybe we should back up a step and say, hey, I think we should save your teeth and do some restorative work here.
Yeah, I mean, really it takes the visualization, of the solution out of the equation, because usually that's just in your mind or the doctor's mind, like, okay, well, this is what I can do. And then you have to articulate that to the patient, and, a lot can get lost in translation. but we're going to the solution now, which I love. And, you asking the patient, if I can do this, will this make you happy? Like, is this what you want?
Right. And the solution has the patient's face overlaid on it. Definitely something that I want to show at this point, Naden, in here, where we get you some of those 2D images with the smile creators on there with the design software. But to show some examples of that, it also, I think, really, really helps when a patient is like, hey, I just want to do my upper. I know I need to replace my uppers. I'm going to keep my lowers for now. That's a pretty common one we get. And sometimes that is doable, and we do a decent amount of that. But there are times when the lower teeth are in such a poor position that just replacing the uppers, it makes us arrange the teeth either in a way that they're really unattractive and phonetically really affect the patient's ability to speak clearly, or it gives us a really nice looking upper that doesn't line up with the lowers at all because they're out of position, and then the patient can't chew. And I think that patients sometimes, when we say, hey, we do that, but you're really not a good candidate to do both arches, I think visually showing them why, when they see those teeth that aren't lining up, it'll really be an aha moment to where they can go, oh, yeah, I'm going to be on a mashed potato diet. I've only got a couple spots to chew on.
And we see that a lot because the patient comes in and they're like, well, just my upper's busted. Lower's fine, just want the upper. And then we can take these scans, and instead of the patient feeling like we're trying to upsell them to do the lower as well for their best result, we can show them and be like, hey, this is what it's going to look like if we just do the upper.
Yeah, sometimes I think they think that we're pretty anal and that we're trying to get them to 100% perfection. And they're sitting there looking at their personality and they're going, I'm fine with a 80% or a 85% or a 75% or whatever it is. And then when we show them the way that the teeth would need to be arranged to work out well for them and what their anatomical limiting factors are for where we can put those teeth, I think it's going to make a lot of patients realize, like, oh, it's not a 75. They're going to give me a 30, which is why they're saying no. Hey, we either do both arches or we don't do it. And I say that all the time. Like, I would much rather see you not do anything than to move forward with one arch. On the flip side of that, it confirms for some of those people that where you're like, well, those lowers they're not perfect, but they're not terrible. And it really helps me go, you know what? I can make your uppers look really good, and we can make them chew really good. And if you ever did need to convert to a lower down the road, it really helps solidify that for me too, to know which ones those patients are and which ones they're not. Because there is an area where even I have a hard time visualizing, and it'll complete the diagnosis in a much more thorough way than we've ever been able to.
Yeah. I mean, I'm excited to roll that out because it takes a lot of the guesswork and visualization just off the table.
Absolutely. The more patient can see, the more they can understand, the quicker they can understand more completely. And once we get to that point, then it's just a matter of coming to terms on the process and the cost of the procedure and getting everybody on the same page there. And, within a few weeks, we hit the green light and they're done and looking back and really telling us that they wish they'd have done it sooner.
Yep, absolutely. Hear it all the time.
Yep.
But so really this just adds a scanning appointment to, not really an appointment, but a scanning procedure that we do in the initial consult. And then once we have that, we can start with the tooth setup, and then we have everything we need, right?
Yeah, so the patients that, get to the consult level are going to get to see the exact same teeth that we would be designing and what we've been doing right now the day of surgery. So we're just moving that digital step up to the diagnostic phase, to the consult phase. We've been doing this step. We just haven't been showing people at the consult phase, and we're just moving that up in the process. And the main reason we haven't done it in the past is not because we haven't had the capability for some time. It's just a logistical problem with scheduling and working out. If I'm over in the general clinic seeing patients and doing procedures, while you're doing a consult. We just haven't had the manpower really to pull it all off at one time. And, with Dr. Maddie coming in and helping and taking a lot of the burden off of me for some of the other things that I've been doing over the years, it's really going to free us up and allow us to be more thorough here.
Yeah, and it is nice with the new technology, even if you do get caught up in those situations, myself or one of the assistants can take the scans, and then we can always schedule the patient back for a Zoom consult, go over it digitally. They don't have to come back into the office. We have everything we need, treatment plan presentation, everything through the computer now.
Yeah. For people that, they don't want to come back for that next visit. Some people do. They want to come back, and that's fine. And that's great. And we welcome that. Being able to see people is an opportunity to make relationships stronger, I think. But, it is a convenient tool to use to be able to use Zoom. And as far as understanding it goes, we're just looking at screens. So whether you're looking at your screen at home or our screen in the office, the understanding level is the same. So, don't feel like you're going to miss out on something other than just, getting to see our pretty faces, I guess.
Yeah, get to visit us in the office.
Mostly Chris, yeah.
Yeah, Sheila.
Yeah,
Get to see Sheila at the front desk.
Well, some of the girls.
So jumping back, so anything else you want to say about the new scanning appointment and, that so forth?
Yeah, I think just to let people know that, we're always trying to get better. The process has been evolving ever since I started doing full arch, over 10 years ago, and technology's evolving. And so we're staying with it and evolving, and I look for that to continue. The entire thing just keeps getting better and more efficient, and I'm pretty excited that we're on the front of that curve. Yeah,
it is exciting. I want to jump now back to something you touched on earlier, and that's the spending money in the wrong direction. We have that conversation a lot in consults. Hopefully, in the consult, we're having that conversation before they've spent money in the wrong direction. Unfortunately, sometimes, we're seeing patients from other places and they've already had a lot of work done, and, they've kind of already spent that money in the wrong direction.
Yeah, even just in the last couple of weeks, I can think of 2 different scenarios where a patient either just got a crown in the last 2 weeks or just got a bridge. So they've spent $1,000, $2,000, $3,000, $4,000. And, and in one of those scenarios, the doctor that did the bridge had sent them to see us. And I said, unfortunately, that bridge was made to fit where your teeth are, and what you're telling me is that you want to make your smile look better and you want to complete some of these missing spaces. And if we keep that bridge, that would sort of force us to work with the position of those teeth, because those teeth were made to fit the teeth above them. In this case, it was a lower bridge. They were made to fit the teeth above them that were really super erupted and unattractive in this person's smile. And so, with a little bit of education, she was able to say, I get it. That actually makes total sense. It really sucks. But, I said, right, we're looking at making a life-changing decision for you. And as bad as it is, we don't want to let what happened last week get in the way of that.
Yeah. So. Yeah, that's one. See you, Bear. He had enough.
He gets tired.
Yeah.
Works hard.
The other one, that we see, whenever we're in there and we're diagnosing work, and I just have a problem on my upper right. I got an upper left bridge last year. I just need it here. Maybe even just if you just put a single in here, and then I could always upgrade that single to the implants, or a fixed option later on.
Gotcha. Yeah. So a lot of times a patient has a very problem-focused area. I'm missing a tooth here. I've got a tooth that hurts here, and they just want to focus on that. And a lot of times they want an implant to replace it, and they say something like, I know I have other things going on, but let's just start with this implant, and then as I lose these other teeth, I'll add implants, and then eventually I'll have all implants. And that is possible. It's not that is impossible. It's just that from a construction standpoint, is a really poor way to build something. And it's a really great way to spend probably twice as much as it would actually cost to do a full arch if you just planned it and did it all in one seamless process. The amount of hours under the construction phase when you piece it together, when you sort of piecemeal a prosthetic like this, is anywhere from double as many hours up to probably 4 or 5 times as many hours, depending on how long of a transition this is. Sometimes this transition is years long. And so you can imagine that buying a single implant here and buying a single implant there gets really expensive. And then on top of that, they're just not in the right position for a full arch prosthetic. So many times when we do these prosthetics, we call it giving you overnight ortho, because we now, when we remove your teeth, have the ability to move these teeth, much like in orthodontics, into a much more ideal position. And your implant that was placed for this one tooth that was made to fit all your other teeth where they were positioned doesn't relate well to where the arch form of the full arch prosthetic would need to go, because we're going to make it better. If we're going to do it, let's make it as good as we can. And so that is something that a lot of patients, I think, conceptualize that they can just sort of add on, and it just doesn't work out very well. It's more expensive, way more expensive, and it does not work out. And I'm here to tell you, I tried it for years. Like when I started doing full arch, I was very much of the mindset of like, I'm going to make this work for people, whatever works. And I just learned the hard way that there's just limiting factors on the thicknesses of the layers of the prosthetic, and they just end up breaking.
Yeah. I've seen some X-rays.
There are some gnarly looking X-rays out there.
Yeah. I see them back in the office when we're converting them.
I mean, a lot of times, and I've seen other patients come from other offices too, where, I remember a specific story where a gentleman had come from a doctor's office in north central Missouri, and he said, my doctor can't get my implants to fit on my denture. Well, his implants were made for single tooth crowns when he was just missing a few teeth. I think he had 4 or 5 implants on his lower jaw. And then that doctor, being the very nice, wonderful person she is, was trying to work with that so that he didn't have to spend more money on more implants. But all the implants were placed at different trajectories and angles to support the teeth that they originally had been used for. And when you make them to support a full arch prosthetic, we need them, they don't have to be perfectly parallel, but we need them to be fairly parallel. There's maybe a 25 to 30 degree divergence. You really can't go over that, or it makes the project very difficult to do. And she was basically working with a foundation that was pretty unworkable. And I mean, he kind of came to me thinking I was the magician, like I could fix it. And really all I did was tell him, like, we gotta take those out, put in new ones at the right position, and then we can build you something great that you'll really like. And that's what we did, and he loved it.
Yeah, and that's just from the foundation was wrong for what he was needing.
Yeah, imagine, having this little tiny house, and we make this concrete foundation for that, and then time goes by, and we want to add on, and we want to add on, and we want to add on. We add on a garage, we add on a second bedroom, and they're different. Now we have multiple elevations even. Maybe the house is on the side of a hill. I mean, you just get to where it's so cobbled up that you got a leak here, and the foundation's settling there. And I mean, this is my construction analogy, but that's what's happening. I mean, that's a pretty solid analogy when you try to piecemeal this thing together. It is a very frustrating thing for the patients because they can't understand why it doesn't work, because they've spent thousands of dollars on implants over the years. And if they make that kind of investment, they feel like they should have something that's really good, and they should. But it wasn't made towards the type of prosthetic that they're now being converted to. And on rare occasion, it works, but it is very rare. I would say less than 3% of the cases I see.
Yeah. One other thing, you kind of triggered a little thought there whenever you were talking about the implant per tooth. I do have a lot of people come into the consults, and they're thinking they need an implant on every tooth. They want to replace them all, and then they look up national averages for a single implant, and I think the national average is around 5,000. And they're like, well, 5,000 times, if I'm getting 12 or 14 teeth, I'm spending $60,000, $70,000. Right. That's way out of my price range. I can't do anything like that.
Right.
And then we come in and we just, show them our prosthetic. And how many implants are we doing on the upper now?
Yeah, traditionally most of our upper jaws get 6 implants. It's 6 If you can get more than that, my philosophy is very much like, I'll put in as many as your jaw will support, because that gives us a better chance for long-term success. And so, but traditionally, and humans are as variable as we are, we also have a lot of commonalities from an anatomical perspective. Like, anatomy is a dead science, hasn't changed since it began. And, most people have room for 6 on top as kind of a limiting factor. Once in a while you find somebody with 7, and all the way down to 4. We'll do the prosthetic with all those variations of implants. Sometimes when you have larger sinus cavities to where you don't have as much bone on your upper jaw, it's fairly common. We'll do a prosthetic that has 1 less tooth on each side, but the patients are still super happy with it, and cosmetically it doesn't affect them. So 6 on top and usually 5 on the bottom.
Have you found any correlation yet? I'm still trying to find some, because I've seen some little old ladies that just have some lots and lots of bone up here for implants, and I've seen some big old guys that just 0 bone up there.
Yeah, just you don't always get your genes from mom or dad. You get a mixed bag of everything, and I think that's genetic. Like, I think the way that our bones resorb after our teeth are removed is factor of genetics more than most things in the dental field.
Back to one of the original questions in the opening. Should I save my teeth, or have I gotten all my use out of them and it's time to replace them?
Yeah, so it's the foundational question in all the consults. And it is the question that doesn't always get discussed in the room, because the answer is sometimes so obvious. The patient comes in, they haven't seen anybody in years, and they have decided they're getting their teeth out, and it's for obvious reasons. It doesn't take a dentist to figure it out. So sometimes it doesn't get talked about at all because it's the most obvious answer. And other times it's the least obvious answer. And but I want everybody to know that it is the question that I ask myself every single time, and that any of our doctors do. But should these teeth come out? Like, we're never going to tell you to take your teeth out if you're not wanting it and we don't feel like it's the best thing for you.
Yeah, I love, in the consult, you always make the analogy. If you were my mom, if you were my sister, if you were my brother, this is what I would tell them. I think that hits home, to all of our patients. And it hits home because it's 100% honesty. You're telling them the truth.
Yeah, these cases are almost like becoming family members with people. You're spending a decent amount of time with them, and you're doing something that's so intimate to their personality, to their way that they broadcast themselves to the world, that, it's a big decision, and it affects kind of everything after that. So we don't take that decision lightly, and making sure that, we feel like, based on the goals that you present with from our discovery form, and really the chief complaint that the patient has, that, coupling that with their x-ray and the objective factors that we're looking at in our visual exam, that we can usually, if I ask myself that question, what would I do if that was myself? What would I do if that's my mom? What would I do if that's my sister, my dad, my brother, whatever it is? When I find myself, when I'm kind of on the fence about making that decision, and then I ask myself that raw question, I call it it-wit, by the way. If they were your teeth, it-wit. Once you ask yourself that it-wit question, it seems like the answer becomes pretty clear, manifests pretty quick.
What are those visual factors that you're looking at?
Rampant decay. We've just got decay everywhere. It's probably the one that everybody thinks about the most. Severe gum disease. Gum disease is nothing more than bone loss, basically, around all your teeth. Smoking, we see, most of our cases have, these are the correlating factors that most of our cases have. And it's not that the cases have all of these factors, but it's that it's very rare that we put a person in prosthetics that doesn't have 2 or 3 of these factors. So if you're a patient that has 2 or 3 of this group of factors that I'm really bringing up, then you want to make sure that you're really getting evaluated well before you would spend large amounts of money on saving your teeth, like bridge work or single implants, things like that. Rampant decay, gum disease, smoking, sleep apnea, severe wear on your teeth is a common factor. Multiple missing spaces. So if we're missing more than 3 teeth, there's probably a reason for that. Hygiene, just I don't brush that well. I haven't cared that much. A lot of times hygiene is a factor of how proud a person is of their smile. And they won't even tell you they're not proud of it anymore because they'll usually say something like, well, I don't really care about the way my smile looks. It's not really that important to me. But that's because they've never had a nice smile.
Mm-hmm.
You know, that's because they've never been able to broadcast themselves that way. And
You also ask that patient to smile in the consult, and they can't. You're like, hey, smile, show me your teeth.
yeah, they're here at the dentist to be evaluated by their teeth, and they just
And they won't show you.
can't really show you. So, yeah. So, you know, hygiene is a big factor. And in my opinion, once we make them look good, a lot of people do actually get better. And these prosthetics, in my opinion, are easier to clean than natural teeth, especially when you have natural teeth that are crooked and just have nooks and crannies in them that are really difficult to clean, or you got to get in there weird with floss, stuff like that. So yeah, those are the big factors that I see. I'm trying to think. And then just multiple, sleep apnea is a big one, man. People that mouth breathing, there you go. Mouth breathing, tooth wear, and sleep apnea all go right together. And there's 3 main reasons for tooth loss. It's rampant decay, it's generalized gum disease, and it's trauma. Trauma encompasses tooth wear, sleep apnea, and what was my other one there?
The mouth breathing.
And mouth breathing.
When you say mouth breathing, are you talking about like dry mouth then? Like, is that kind of the, whenever
No, that's
you do?
another factor I missed.
Okay.
So dry mouth is separate than mouth breathing. So if dry mouth is usually a side effect of being on medications like antidepressants and blood pressure medication. Those are the 2 most common categories. There's a lot of medications that cause dry mouth, but those 2 really significantly change the saliva output. And I'm here to tell you guys, if you're on those medications, you are getting decay. And you can probably, if you have good hygiene and care about taking care of your teeth, you can probably trace back to a time in your life when you had a much more stable dental condition. You went to the dentist and didn't really have many problems. And then you started those medications, and all of a sudden, every time you go to the dentist, you've got 2 or 3 new cavities. You got I need 2 fillings and a crown, you know, or wow, that one's so bad it broke, or I have to have it removed, or a root canal, whatever it is. But the dry mouth is a big factor as well. But the mouth breathing is a factor of your airway, and the amount of size that your airway has, especially when you sleep, tends to relax and close down. And so there's a lot of research that points tooth clenching while we're sleeping, like really severe tooth clenching, toward the worn teeth and sleep apnea. And it just connects the dots between our ability to breathe easily at night and get the oxygen we need while we're sleeping, and get quality sleep, and then tooth wear. So those are the big factors. But if you have 2 or 3 of those group, and this information is coming up on our website, that you guys can check that out. But if you have 2 or 3 of those groups, it's probably a good thing to start educating yourself on what types of things are out there in dentistry to become a more stable dental patient. So if you got 2 or 3 of those groups and you're unstable, that might be something to look into.
Yeah. So that kind of just, once you see those, that kind of puts your brain more so in a mindset of like, if I would restore these teeth, how long is this patient going to be able to use them before those factors factor into either those teeth you restored or the adjacent teeth that now need to be replaced?
Yeah, those factors usually correlate to a mouth of problems, not a tooth that has a problem or 2 teeth that have problems. So it's really hard when you have a group of those factors, you have so many risk factors for ongoing future problems that spending a lot of money today on an area like, hey, I'm missing this tooth on the upper right, I got a cavity there, let's fix it. Spending a lot of money in an area a lot of times just is chasing the storm. You never get ahead of the storm. And it's totally related to risk factors. There's nothing worse for a dentist than seeing a patient with a ton of risk factors that wants to fix a small spot and doesn't want to fix the whole mouth, because all we're going to do is see you back next year with the tooth right next to the ones we fixed, or even the ones we fixed that aren't doing well, because you just weren't a good candidate for restorative work. And that happens all the time.
Yes, it does.
So, yeah, a lot of content there. Maybe a wrap up?
Yeah. Well, thanks for joining us. This has been episode 2 of the SmileLine podcast. Make sure you guys like and subscribe and comment.
Yeah, guys, give us some feedback. This is something totally new to us, and our goal is to get the information out and get the education out. So give us some feedback, because we want to make this as good as possible for you guys.
Yep. See you guys next week.